All right, what do you say we kick this thing off tonight, huh? So good evening, everyone. I'm Dr. Julie Tennille, Principal Investigator and Program Director of our Health Resources and Services Administration grant focused on interprofessional education and integrated care and branded EPIC for education and programming in integrated care. I join our talented EPIC team, Dr. Cheryl Neal McFall, Wendy Myers, Fatima Bakayoko, and Sarah Fisher, in being honored and thrilled to bring you this special fourth and final event tonight entitled Responding to Infectious Disease Epidemics Through Innovation in Interprofessional Practice. This presentation will be delivered by Dr. Linda Rose Frank and Abby Plusen on behalf of the MidAtlantic AIDS Education and Training Center. So let me say a little bit more about our two accomplished presenters. Linda Rose Frank is Professor, Department of Infectious Diseases, Graduate School of Public Health with secondary appointments in School of Nursing and School of Medicine at the University of Pittsburgh. She is currently the Principal Investigator of the MidAtlantic AIDS Education and Training Center funded by DHHS HIV/AIDS Bureau. She has been on the front lines of the HIV epidemic since 1988, providing training, consultation, and technical assistance to organizations, clinics, programs with a particular focus on HIV, community health centers, prisons, and other health settings in the US and around the world. Prior to her appointment as faculty, she held clinical leadership positions in psychiatric inpatient and emergency services at WPIC at the University of Pittsburgh. Dr. Frank is currently working on a HRSA-funded COVID-19 education project and an NIH COVID-19 research project in community settings. Abby Plusen, with a Master in Science of Social Work, has over 20 years experience in the field of HIV/AIDS. And as the Director of HIV/AIDS educational programs at the University of Maryland, Baltimore, Abby manages the local performance site of the MAAETC, where she is one of two Maryland regional coordinators. As a social worker, Abby believes strongly in trauma-informed approaches to care. So let me just get a few housekeeping items out of the way for tonight too. So due to our number of attendees, as you can tell, you'll be muted throughout the presentation tonight. If you have a question for the presenters, please enter the question in the chat box, and Fatima Bakayoko will be collecting them and posing them to our presenters at the end of the evening. And this is really important because I think a lot of you are here to get your continuing education units. So for those of you needing continuing education credits, you have to complete both the pre and the post test this evening. And this is important. After you complete the post test, the CEU link will appear on the confirmation page. Once you click, you'll be directed to a CEU request form. You must complete that form to receive your CEU certificate. CEU request forms are required for reporting purposes. And Dr. Frank, you'll have to unmute yourself.
Sorry. Hi, everyone. Thank you all for being here tonight. It's great to see all of you. And I was scanning through the list of participants, and I couldn't help but notice that the vast majority of people on tonight are women. And since it is still March 31st, I want to honor everybody, all the women on, because this is the month to honor women. And I know that we need to celebrate the work and the contributions of women to so many things. So let me thank you. To all of you who are mothers and grandmothers and daughters and spouses and partners and, you know, all of the things that we do. Thank you. But tonight I'm going to talk about with Abby, and I'm so happy to be here with Abby Plusen. She and I have been working together for a very long time, since the 2000s. And I've been working in HIV, as you've heard, for a very long time. And anyways, so I just want to talk a little bit about the objectives tonight. We're going to talk about the importance of interprofessional practice. I'm going to talk a little bit about the issues that impact interprofessional practice and discuss the impact of the COVID pandemic on interprofessional practice within healthcare settings in general. Abby's going to provide a discussion and a presentation about the IPE program that's integrated into the MidAtlantic AATC that she does at the University of Maryland as a regional partner. And then we're going to talk a little bit about ongoing lessons learned in not just COVID-19, but in HIV and all the other work that we've been doing. So there you have it. And I really don't want this to be death by PowerPoint. So I'm probably not going to be sticking closely to my slides. I'm probably going to be like talking. So please, if you have questions or disagreements, post them in the chat. I'm a long-standing person who's been on debate teams since I was like 12 years old. So, if we're all into groupthink, things never change. Let's move along here. So an interprofessional approach to HIV, clinical services, COVID services, mental health services, really is a patient and family-centered approach, and it's rooted in health, population health, and social determinants of health. It recognizes each team member's role that's critical to one another. But the thing that makes interprofessional practice different than multidisciplinary practice is in interprofessional practice, people come together and find solutions together. And Abby's going to talk about that. Multidisciplinary is really where the doctors are over here and the social workers are over here and the nurses are over here, and they all figure out what they want to do. And then they come in and they say, well, this is what I think. That's not interprofessional practice. Interprofessional practice is people joining forces to come up with the best solutions in a patient-centered approach, using their expertise and using their knowledge. And so Abby's going to talk a little bit about this, when she talks about the program that we have at the MAAETC. Oops. Page down. No, that's not working. Okay, so I'm going to talk about overview of the importance of interprofessional practice in dealing with infectious diseases. I chair the City of Pittsburgh HIV Commission that was put together by the City Council at the University of Pittsburgh. And I've been doing that for a number of years, and I've been on the committee. And we've come up with this model for the City of Pittsburgh that looks at the intersecting public health issues of HIV, substance use, hepatitis, mental illness, and STIs. And as you've heard, I've spent a good bit of time working in psychiatry. I spent about 20 years working in psychiatry before I came to working in HIV. And as a psych nurse clinical specialist, in the days that I worked in psychiatry, people who had mental illness and substance use were at great risk for a lot of health problems. And then HIV came along, right? And that changed things a lot. And it was a very challenging time in the early days of the HIV epidemic because we had no real treatments. People would show up in the ER and die. Now we have great treatments for HIV. We have hepatitis treatments that are a cure. We've had treatments for STIs. Some of them are still not curable, the viral ones particularly. We have medications for mental illness, and we're getting better at evidence-based practices and biomedical interventions for substance use, which I'm sure all of you know about. But things are better. But the problem is that I see is there's still siloing of activities. We got the mental health people over here, the substance use people over here, HIV people. We need much more integration. And that's been a long-standing problem. And contributed to this is how things are paid for. The finances of paying for treatment often encourages those areas staying in silos. So this is our interprofessional collaborative practice model that we developed for the MidAtlantic AETC that was part of our grant application. And as you well know, there's 4 competency domains for interprofessional practice. One is values and ethics, which includes culture, inclusiveness, equity, equality, confidentiality, logistics. Now more important than ever, right? Roles and responsibilities in terms of, all of these things. I'm not going to read them to you, but one of the things that sometimes gets lost is the behavioral health prevention and treatment and evidence-based work in behavioral health. And there are many. I was trained as a cognitive behavioral therapist for working with children and adolescents, and it does work. But somehow there's still this notion out there sometimes that, nothing really works with people who have mental health problems or substance use. That is a myth, because treatments do work for people who are mentally ill. Treatments do work for people who have substance use. Treatments do work for people who have HIV and hepatitis, and all of these intersecting public health problems that we have. The other area, of course, is communication, right? And this is something that, you can't overemphasize. People don't talk to each other, they're not going to learn from each other. Things are not going to change. And, the patient is in the middle of this. You got to talk to the patient and the client and their family, whether that's their family of origin, their family of choice, whoever that may be. And then in terms of teamwork, and teams are tough. To get a good team to work is not an easy thing. I was trained as a therapist, and I trained as individual therapist and a group therapist and a family therapist. The groups were tough. Managing, and you're all most of you are like in social work and behavioral health, so you know what I'm talking about. One-to-one sometimes can be pretty easy, but managing groups, not so much. And in this, we have the concepts of mentoring and coaching and collaboration and partnerships, and what are the resources and what are the supports for folks. And you all know how important supervision is in, the work that you do. To have somebody to bounce ideas off and somebody to offer you consultation, very important. And then the whole issue of communication. So you have, in our model, we're looking at people in practice. We're looking at clinicians and healthcare providers that are in the pipeline, that are in training. And we're looking at the entire group of people that takes care of patients. And it's not just physicians, it's not just nurses, it's patient navigators, it's community workers, it's everybody. Because no one discipline can take care of a patient. They can't. And I used to tell people all the time that, if you only need doctor's care, you don't need to go in the hospital, right? You need to go in the hospital if you're sick because you need all the rest of the people to care for you, not just the doctor that prescribes perhaps the medication or does the surgery. So, all right. So I want to see, I think I missed something. The interprofessional practice journey it's a longitudinal thing, and it's a lifelong thing. And nobody does it correctly every day. And you have slip ups and, you have bad days and, all that stuff. We can't be perfect all the time as much as we try to be. And that's the thing about building teams. You have to be able to admit when you've made a mistake and when things have gone down the wrong path. But I think in healthcare, we're afraid to admit that perhaps what we did was not the right thing, or we did something wrong. And that's really essential to team building, is being able to look at what worked and what didn't. And it's like doing CQI for the team. That's part of quality management, is figuring out what worked, what didn't work. And it's not about blame. It can't be about blame. It's got to be about what worked, what didn't, what are we going to do differently the next time in interprofessional practice, and how can we come together to come up with the best idea for how to work with this patient. So it requires an exchange of perceptions of views of self and others. And, doing interprofessional practice, you really do have to look at yourself. And, when I worked in psychiatry, we used to do interviews behind a one-way mirror, and we got our interviews critiqued by the whole team. And that was really tough. And also videotaping yourself and looking at yourself and what you look like when you're running a group or when you're doing individual counseling with a patient, that's very telling, because sometimes people are not good at controlling their face, right? And you have to be willing to, have to know how to control your face. And group dynamics, as I said earlier, can be challenging because there's change in members, there might be a crisis or other events within clinical settings and outside that can result in a regression and dysfunction in the group. We always try to tell people, well, you got to leave your personal life at the door, but sometimes that's not so easy. When there, and all the things that can happen. So working groups can be fragile, and we need informed and skilled leaders in groups. And a lot of times, and you're going to hear Abby talk about the champions that have been developed in the IPE model that she's going to talk about. And communication role definition requires continuous maintenance because people's roles change. And we know that interprofessional practice works. It improves coordination, it reduces tension and conflict, it improves clinical outcomes, and it lowers rates of turnover. So, what's the impact of the COVID pandemic on interprofessional practice? Now, we just presented before the City of Pittsburgh HIV City Council a couple of weeks ago, and I changed the schematic to put COVID-19 in this schematic and disparities, equity, and inclusion as part of it. Because one of the things that COVID-19 has done is it's highlighted disparities. It's highlighted, the issues of equity and inclusion. And all of us are working on those things as we simultaneously work on all of these other issues. And I'm sure that you've been talking about this in the course of the work that you've been doing as well. I just want to mention here, just for a moment, the Ending the Epidemic Plan for America. And there's 4 pillars to the Ending the Epidemic. Diagnosing people, treating people with antiretroviral treatment, preventing HIV transmission by reducing people's viral load so that they can't transmit. Because if you have an undetectable viral load, you are unable to transmit the virus to somebody else through sexual behavior. And the other thing is to getting people on pre-exposure prophylaxis or PrEP so that we can prevent people from getting HIV infected to begin with, and then responding to outbreaks. And just recently, over the last couple of years, and more recently in the past several months, we've had an outbreak of HIV in West Virginia as a result of the sharing of syringes among injection drug users. It's happened now in Charleston. We had another one in Cobble County, which is on the border of Kentucky. And so this is a big problem. And it's a problem with people who use substances, in terms of getting HIV infected or getting hepatitis. Same with people who have mental illness, and the population in general. And so I'm not going to read this to you. This is what we're doing as an AETC in responding and working with these pillars. But if you take this model of ending the epidemic, you can apply it to hepatitis, right? Because we want to diagnose people and get them into treatment and prevent people from getting hepatitis. And there are people that are using the same kind of framework to think about mental illness and substance use and, all of these intersecting issues, because we want to do this for everything. We want to diagnose people. We want to prevent them from developing these disorders. We want to offer them treatment and services. So let's move on here. The HIV care continuum, as we talk about in the work that we do in HIV, is we want to do primary prevention. We want to do testing and diagnosis. We want to identify their infection. We want to give them treatment, and we want sustained viral load. And here are some barriers and challenges, which, you can all look at. A lot of it has to do with, access to good information. A lot of things about untreated mental illness and untreated substance use and homelessness and all of these things, unemployment and housing and health insurance. But in terms of facilitators and opportunities, one of the things that we're talking about tonight in this schematic that I developed is the facilitator being that interprofessional practice can be a facilitator to be able to address the barriers and challenges, right? Because I don't know everything there is to know about everything. And, as much as we like to do that, and, I'm a nurse, and nurses really, we want to make sure we, make our lists and know what we're doing, all that kind of stuff, but it's impossible to know everything, and the literature and the new practices and new ideas, they change every day for a lot of these things. And even if, I work in HIV, and it's impossible for me to even keep up with all the HIV literature. It's just humongous. The same in substance use and the same in psychiatry and, all of these disorders. It's tough to keep up with everything that's going on in terms of best practices, evidence-based interventions, all of that stuff. But IPE is really important to addressing all of these barriers and challenges. So what are the issues related to infectious diseases that impact interprofessional practice? I developed this schematic a long time ago, like in 2011, and I revised it recently. Because if you have a client or a patient who has HIV, they need HIV specialty care, they need primary care, and if you're a woman, you need OBGYN care, right? And you need linked to psychiatric services, substance use services, case management, and peer navigation. And you have to do outreach, and you have to give wraparound services, support services, because, just giving people medication doesn't work all the time. It might improve their depression, right, if you give them antidepressants, but it doesn't really take care of all the issues that may have contributed to them having a situational depression, for example. But now we added in here this COVID-19. Who knew that was going to happen, right? Well, some of the people in infectious disease predicted that we were, that some kind of pandemic like this was eventually going to happen. I'd hoped that I wouldn't see it in my lifetime. But unfortunately, it has happened. And now all of your patients, whether they're psychiatric patients, substance use patients, HIV patients, COVID-19 is thrown into the mix now. And what we've seen in the community is because of COVID-19, we're seeing rates of alcohol consumption going up. People are smoking a lot more pot. People are, we're having more overdoses. So it's really added another layer of complication to an already complicated situation. And then this schematic, which I developed a long time ago too, recently revised, is, when you think about HIV, you got to think about all these other things. Substance use, mental illness, we talked about, but domestic violence and other forms of abuse are need to be part of the conversation and part of the assessment that we do with all of our clients. Homelessness, unstable housing, food insecurity, all are things that we've seen with HIV and people with mental illness and substance use in the past. But now with COVID-19, it's accentuating that, right? We have more people that are unstably housed, and a lot more people with food insecurity because of the financial strain that COVID-19 has put on things. And then, one of the areas of work that's near and dear to my heart is working in prisons. And I spent about 10 years doing education and training in the Pennsylvania Department of Corrections in every prison in Pennsylvania, training their staff. And I developed a peer education program for prisoners on HIV prevention. And I went and trained peer educators in prisons across Pennsylvania. And I have to say, it brings tears to my eyes, honestly. It made such a tremendous impact of prisoners, wanting to contribute some good. And, prisoners were lined up to become peer educators. They wanted to make a contribution. But anyways, you have to sort of consider that. And intersecting all of these is the issue of trauma-informed care. And so Abby will probably talk about that a little bit in her presentation too, but that's an important thing to remember here. Now, another area that I don't think maybe some of you have talked about, maybe you haven't, but we have one labor force right now. And within that labor force, we've got 5 different generations. And you hear about this stuff all the time, the traditionalists, those people in the workforce that were born before 1945, that number's dwindling, right, from the workforce. We got the baby boomers and the Generation X and the millennials, and the Generation I are the alphas, okay? And I borrowed this slide from my colleagues who work in labor management. And it's one thing that we often don't think about in terms of interprofessional practice is that we have all these different generations in the workforce that actually do have an impact on how people do work together or don't work together. So let me just say something about values of these different generations. I'm not going to read this to you because you'll get these slides, but traditionalists, are, great work ethic, loyalty, patience, their structure and consistency. The baby boomers like me, we work forever, and, we don't have a good, work-life balance, It's been my problem all my life. And I don't think I'm going to change now, but who knows? And they're into teamwork. Generation X, autonomy, informality, ongoing learning, feedback, balance. They're good at the work-life balance, right? But they want feedback, right? And they're informal. They don't like to call people doctor, right? For example, or they don't necessarily follow the chain of command when they want something done or they have a problem. They might go directly to the top, right? And millennials are really interested in achievement and structure and collaboration. But amongst all of these generations, the one thread throughout is the importance of respect. And that's something that I think, in terms of interprofessional practice and working and having teams work together, that's so important. and having and being listened to. And so these intergenerational this intergenerational workforce has potential for conflict, because many of the organizations that we work in are very hierarchical, right? And that sort of flies in the face of how different generations think about how they want to do their work. The role of seniority and qualifications, that's important to some generations, to others it's not, right? Why shouldn't I get paid the same as somebody who's been working here for 15 years, right? Managing change, getting feedback and input and involvement, how people want to communicate. I'm a baby boomer, so I like to pick up the telephone, right, and call people. But there are some generations they'll send a text, right? But it's different for different generations. And then approach to work and time and the work ethic. And down here in the corner, we got this little kid who's saying, Grandma, listen, double click on the Internet Explorer icon, right? The little kids are doing better lots of times with technology than adults are. And we use technology, and does it mean that communication is better? Because it often can lead to misunderstandings. And we know that people say things in an email that they wouldn't say to somebody's face. And that happens a lot. It reduces real-time interaction, and people use technology to avoid talking to people. Well, I'll just send this person an email. We don't see eye to eye on these things, so I'll just send this person an email. And it becomes a barrier to communication. Can be a generational preference, skill, or deficit. And it can also get you in trouble. And they tell you never put anything in an email that you wouldn't put on the front page of the New York Times. I still abide by that rule, right? And many of you have probably had the unfortunate accident of replying all when you didn't really want to. So anyways, so think about that when you think about interprofessional practice and the generations that exist within the workforce. So when we talk about engagement in HIV care, it really involves a team, right? This is a schematic that was developed by HRSA on, the spectrum of engagement of care. And we basically want people, and this is not just for HIV, this is for people with mental illness, with substance use, with hepatitis, with diabetes. We want them to get into care. We want them to know what's wrong with them. We want to get them into care. We want to link them to treatment, and we want them to stay in care. And it doesn't matter what you have. We want people with all kinds of chronic conditions to do that. And that's why the team is so important, whether it's HIV or diabetes. So, institutional structural issues that may contribute to difficulties in interprofessional practice. Funding for care, the experience of the team, the disciplines, the generations. People worried about promotion and performance assessment processes. That gets back to the things that people don't want to do anything wrong, and they don't want to admit they did something wrong because it's going to affect their performance evaluation, right? Changing policies, group dynamics, technology, how the organization is structured. When you get a new person at the top of the chain of command, you're bound to be changes, and that makes people anxious. We just got a new dean at the Graduate School of Public Health, and is coming in, and we're doing a lot of things differently. It's great, but it does add an element of anxiety in organizations when the leadership changes. It's just the way it is. And then the institutional politics. And there is politics in institutions. It's not just in Washington, D.C., right? But there's politics. It's everywhere. And, when I teach students and they say, well, I'm really not into politics, and I don't want to be involved in it. I say, well, look, you got to think about that because you have to understand it in order to use what's going on and the understanding how politics impacts what's going on to keep things moving in the right direction. And then psychosocial issues that go on in institutions, people learning jobs, finding a mentor, finding somebody that you can talk to and give you information, determining what your career path is. When I grew up deep in the last century, you you picked a a career and then you stayed in that for the rest of your life. I didn't actually do that, because I didn't really want to. And I've done a lot of different things, but figuring out where you want to go next is important. And a sense of belonging is also important that affects how teams work together and how IPE, interprofessional education and interprofessional practice, can be bolstered. Feeling competent in your area of practice. And in terms of adapting to change due to the pandemic, there was a lot of things that were going on in work environments that were tough. Access to PPE and requirement, like in the early days of HIV, we had some of those issues, but not like we had for COVID-19, because it was an airborne transmission, right? Concerns about family and others, as well as self-care and wellness. And we hear a lot about people feeling isolated and being anxious in this pandemic. And, we're all working from home. I'm live from you from my attic. I'm live to you from my attic, which I remodeled for some reason about three or 4 years ago. I didn't know why, but now I know why. So anyways, and self-care, those are, the women and the men and the people that are on this call, women, sometimes we put ourselves last on the list, right? We got to think about that and figure out how we might need to change that. And engaging in interprofessional teamwork can help you feel like you don't have to do everything and you don't have to know everything. And people have better ideas than you do. And that's great. It's great. And then I want to talk about culture within institutions. Perceived specialized expertise. If I'm an HIV person, they expect me to know everything about HIV, and I don't. I don't know everything about psychiatry. We talked about hierarchy. Another area that's become in the fore is equity and inclusion in staffing. We want our interprofessional teams to look like the people that we're caring for. And that's got to be in the conversation as we build interprofessional practice within our settings. And the reduction of stigma related to infectious diseases. There's stigma around HIV, hepatitis, STIs, mental illness, substance use. They're all stigmatized. And it's a little bit better, but it's not great. If you talk to people in the community. I talked about concerns about blame for errors or missteps. And, lots of us, say, if you want it done right, I'll just do it myself. That's not interprofessional practice. But sometimes, that's what happens. And being assigned responsibility to the individual. It's your patient. It's your client. Well, that's a little bit not accurate. In fact, that's a lot not accurate, because the patient or your client, they're at the center of the team. They're at the center of the interprofessional practice model. And then, all the rest of us, and they've got to be engaged in, figuring out what's next. They're a part of this interprofessional team. And we don't have a lot of leaders that are trained in IPE. So this is my last slide, and I'm going to turn it over to Abby. This is from the National Academy of Medicine, and it's factors affecting clinician well-being and resilience. And I put this up here because I think it's really important now. You know, wherever you're working, you know, whether you're in an outpatient, ambulatory, or inpatient, or working in a community program, or a mother working at home with her kids, or a father working in a business, you know, this whole issue of wellness is very important. And they're impacted so much by all of these things: social, culture, rules and regulations, organizational issues, which you talked about, the learning practice environment, healthcare responsibilities, skills and attitudes, and personal factors. And so the clinician well-being, and that's you, has an impact on the clinician-patient relationship and ultimately on patients' well-being. They're all interconnected, and there's no way of getting away from it. So if we're not well, and we're not thinking about ourselves, and thinking about the team and our fellow colleagues in terms of health and wellness, it's going to impact the well-being of the clients and the patients that we see. So I'd like to hear from the group about what they think about these things and things that you've figured out within your clinical settings. And so now we're going to move on to having Abby talk about the IPE program that was developed at the University of Maryland as part of the MidAtlantic AETC. Abby.
Thanks. And thank you, Dr. Frank, for your kind words in the beginning. I'm so privileged to present with you as well. And we have been working together for over a decade. So I will invite you to jump into any part of this presentation. I think you know this program as well as I do. And so if there's something that you want me to pause and highlight, or that you want to pause and highlight, please jump in, Dr. Frank. You said earlier that we have siloing of intersecting public health issues. And we also tend to silo the disciplines that are working in those issues. So the need for interprofessional practice really comes down to what you said. It improves clinical outcomes for patients. So we absolutely should be working interprofessionally. We each bring something unique and incredible to the team. We are as critical as one another, but no one is more critical than another in our teams. And I think that this is when you work interprofessionally and when you work with two or more disciplines to really look at not just your patient, but our patient, you'll start to see those outcomes improve. And I think that you'll improve too as a practitioner, no matter what discipline you're coming from. This is an outline of our model. We have 6 schools at our graduate program that are participating in our interprofessional program. It is called Preparing the Future. As we look to educate emerging healthcare providers, we feel that we are literally preparing the future to work together to provide better care for our patients. So we have the School of Dentistry, the School of Social Work, the School of Nursing, the School of Medicine, the School of Law, and the School of Pharmacy. And it's important to highlight here that our program is a little bit unique in that we work with the School of Dentistry and the School of Law. A lot of the IP programs across the country that are funded through the AIDS Education and Training Centers don't have the opportunity to work with their law schools or their schools of dentistry. We are really pleased and excited that we do, and they bring a lot to the table. So I'll talk a little bit more about that. But at the bottom, just want to highlight that there's 2 programs or 2 parts of our programs, the academic and curriculum integration. And then we're really dedicated to the practice component too, which is service learning in community and clinical settings. So we are not only providing clinical preceptorships and opportunities for clinical engagement, but also outreach and linkage to care and working directly in the communities that we serve in Baltimore. We are guided by the ending the epidemic and the principles of those pillars that Dr. Frank just spoke about, and then wrapping around everything is the MidAtlantic AATC. So the MAAETC lends itself to us in terms of a ton of legitimacy to our program. We are able to fund our faculty champions that come from each of these schools because of the MAAETC. We have the backbone of our registration system. We have the expertise of the faculty that sit in our region. So the MAAETC kind of, it looks like a little hug there. It's wrapping around all of our disciplines. So we're really appreciative of the support and integration of that program. Do
you want the next slide, Abby?
Oh yeah, sorry, I said next slide. Sorry, it's hard to hear me. I think I'm so soft-spoken, so please tell me to speak up if you need me to. Our model, we're an academic graduate school. So we had, as I said before, the opportunity to collaborate with these 6 schools on campus and to impact the healthcare delivery setting. We used and operationalized this approach, which we had already sort of been doing in clinic, but understanding that sitting in Baltimore, we have some zip codes of HIV infection that rival that of sub-Saharan Africa. And so what can we do to really affect change in those areas was an upstream effect of very intentionally educating our emerging healthcare providers to work together to provide better care. We had well-established community and clinical partnerships that we could call on already. And we really developed this model in patient, family, community-centered approaches in population health, really looking at social determinants of health and using that framework. Something that Dr. Frank mentioned earlier and Dr. Tennille said is very important to me is coming from a trauma-informed care approach. So not looking at our patients and saying, why do you act like that? Why don't you take your medicine? What's wrong with you? But rather, what's going on in your life? What's happened in the past that may affect some or create a barrier to adherence to your medicines or even wanting to come into care in the first place? And like I said earlier, recognizing that each team member's role is as critical and not more critical than another. You can go to the next slide, please. These are our program champions. I just want to tell you something real quick when talking about having law as a program partner. We were in a case conference, and so I'll give you some of our the classes that we offer. We have an HIV 101 that's taught in a professional manner, so they really go over how to work interprofessionally at the same time talking about using the framework of HIV 101. And we have a testing training in an interprofessional setting, case conference, cultural competencies. So we look at social determinants of health, LGBTQIA issues, criminalization of HIV. We have a trauma-informed care class, and then we have students enroll for a clinical pathway if they're interested, and they can take a class at the end with a standardized patient, so they get some hands-on experience delivering results to patients or dealing with a complicated case while working with an actor, paid actor, rather than in the practice setting. And then they do preceptorships and shadowing and working in our clinical environment, along with, like, as I mentioned earlier, some of the community outreach. In one of the case conferences, I was sitting in, and at my table was a nurse, a social worker, and a lawyer. And it was fascinating to see all of the core competencies of IPE come out. The nurse was saying, well, why would you provide case management? I can do that. You know, and the social worker was saying, yeah, but I have the transportation vouchers and I can, make sure that this person has X, Y, and Z. And I can, I'll file for disability if they need that. And lawyer's like, well, why wouldn't you call me if you're filing for disability? I could really expedite that care. And they're like, oh, really? You could help in that? And they started to understand like the way they were even communicating with each other, their roles and responsibilities, their expectations of what would come out of this teamwork process, just sitting in a case conference and really working through some of these very intentional debriefs. They started to understand like, wow, we actually have a lot more if we pull our resources than just me trying to do everything for you. I can file the paperwork for disability or even maybe for a name change, but if I can hook you up with the medical legal partnership and I can act as your advocate, as your nurse, and work in conjunction and tandem with the lawyer that we have on staff there, then we could get a lot more done, perhaps remove some barriers to care, and hopefully improve clinical outcomes. So none of this would be possible without what we call faculty champions. These are our faculty at the 6 different schools. They meet every other month. We all get together, we share resources, we talk about publishing papers, we talk about our curriculum. This is where we do our curriculum mapping, what's coming down the pike. We really need to have the class on COVID. We've got to have a specific class on advanced care planning. These students really need to understand how that is going to come into play during COVID. So this gives us an opportunity to constantly be looking at what is it that we're offering these students? How can we pivot in the time of COVID and move online? Sorry, I'm just reading this, excuse me. Can you please give us a real example of a case when IP came together for a great patient? Sure, let me do that at the end if you don't mind. So our faculty champions, we have representation from the 6 schools. We are really lucky that every single one of these people is incredibly dedicated to interprofessional education as well as HIV care. At the School of Dentistry, we have a clinic that does HIV testing, and they work closely with our clinic for referral and linkage to care. And so oftentimes they'll even come into our clinic setting and do some dental care for the patients. They can take them into rooms that aren't being used and perform some very basic dental care for them in the clinic setting. And so they're kind of getting an understanding of the patient, and then they become part of the huddle later to say, did you know that this person's father just recently died? They just mentioned it, while I just happened to start talking. No, that didn't come up when I was speaking to them earlier. I didn't even think to ask, so during huddles, a lot of this information can be shared. So these faculty are all working, they're practicing professionals, but they also are all teaching in our program. So this classes that I mentioned from HIV 101 down to the standardized patient. These faculty champions are participating both on the practice side and on the academic side. Sorry, Dr. This might be the video. Yeah, this is a video about our program. We'll just watch this so you can hear from some of the students. It might actually just answer the last question that was just asked, because they do talk about patients.
Okay, so I'm going to have you hide your screen, and then I will do my best to show this video. And in case it doesn't work, which is a possibility, what we'll do is I'll put the link in the chat and you can watch it on your own afterward. But let's, fingers crossed, we tested it before, it should work. But you'll have to stop screen sharing for me.
I have mine up. Okay.
Okay, yeah, so yeah, that's great. Okay, here we go.
When we first got there, it was the FNPs together, the School of Pharmacy together, until we realized this patient was complex and it's just going to take more than what our expertise were, and how we actually needed each other to take care of this patient.
Preparing the Future is an educational program that brings together 6 disciplines across the campus at University of Maryland to to educate them about HIV and AIDS and the importance of HIV testing. The traditional model of health profession school, medical school, dental, nursing is really to spend several years focusing entirely on what you're going to do in your career and not really learning too much about what anyone else does in the healthcare team. So doing this course really opens people's eyes to what other professions have to offer to patients. No matter what the students end up doing in their career, they can take the knowledge that they've learned about HIV and about interprofessionalism with them out into their next steps.
I learned from these wonderful teammates from interprofessional background that I look at one person as a whole being. That kind of gave me that whole perspective about how I should approach individual as a patient.
The days were spent learning from a lot of different people. So I learned just as much from the doctors as I did from the patients, from the social workers, the pharmacists.
Now, looking at the end of it, that I've gotten to represent the client in 2 hearings, now I can say not only have I built a relationship with the patient, but I've also been able to piece together this puzzle to now fit with the legal perspective.
The students have an opportunity to work together in our simulation lab, and after they go through the scenario, they have the opportunity to meet with us and debrief about their experience.
Simulations and standardized patients are, they're an excellent learning opportunity because of one thing. After the simulation is done, you get feedback.
We actually had a scenario of actually telling a patient that they have HIV or they may have HIV or they don't have those results. Which is really hard. So that really got me out my comfort zone. Really did.
Working with the social workers and nurses and nursing students and medical doctors and medical students, and even like the law students, there are many aspects about this complicated tapestry of HIV and AIDS in this country.
When I teach my students, I share with them that illness is not just confined to like what's happening medically, but it's a whole body, it's a whole family experience.
We all come to the table or come to our client interactions with a holistic approach, I think will be that much more effective.
Working there has given me a different perspective. I treat them more as a whole person instead of a disease, and I'm making sure that all of the other parts of their personhood are being managed appropriately so that what I'm doing for their one medical illness has a chance of being successful.
HIV is an excellent example of a disease that really requires interprofessional care. But the lessons learned about interprofessional care really are applicable to so many other disease states. And I think that we can teach students and they can learn that as a healthcare system, we work better in a team than alone.
Understanding that this can be treated and they can live a healthy life. The bottom line is to improve patient outcome. And you can't do that by yourself.
That was amazing. Wow. So that was so great. That's so inspiring. I love it. Wow. I'm sorry, I'm just reacting. Abby, do you want to share your screen again?
Dr. Francis, yeah.
Yeah.
Yeah. So these are our program components. So using our theoretical frameworks, like I discussed, so I won't read everything out loud, just highlight a few things. Very trauma-informed care approach. Really look through a social justice lens and having the School of Law and talking about criminalization and understanding just some barriers to care. Social justice is a big part of our theoretical framework. Of course, the core competencies of interprofessional care. These are our learning components. So we are addressing outreach, prevention, PrEP, NPEP, linkage to care, early treatment, retention and care, and adherence. And we have collaborations. So our faculty champions, when we get together, I think I mentioned, of course, we're planning, we're talking about additional trainings that we need to take to inform ourselves if, as we all say that I'd say that we all come from an HIV perspective first and foremost, and interprofessional one second. So there's no one in our group that is the IPE expert that doesn't have an HIV background. So we're constantly looking for ways to update ourselves about IPE. And then the desired outcomes and intended effects, of course. Self-reflection is a big part of our program. I think the students mentioned that, or maybe one of the faculty champions did, but we really work in reflection, debrief into almost all of our didactic trainings at the end. There's a lot of time for that, and kind of using those core competencies as a framework to do that. Of course, a main goal is expanding workforce capacity. So we offer our clinical pathway students, so students who complete all of our classes and culminating with clinical practice and the standardized patient. They have to write a reflection paper. As I mentioned, reflection is a big part of our program. They have to peer review somebody else's reflection paper. Then we offer them a certificate. So it's a certificate in interprofessional education and HIV. And that certificate has really allowed students to, we have heard firsthand, I got this job at a Chase Brexton clinic. They said because I had that certificate. So we're really hoping to inform the, at the micro level, really hoping to increase the HIV workforce capacity. At the macro level, we're hoping that students who go to practice anywhere as an emerging healthcare provider have the knowledge and the framework of the importance of working in teams, and also the knowledge and the framework that routine testing is so important regardless of where you are practicing, and advocating for that. So if you're going to work in a hospital setting, even if you're working as a school counselor, as a social worker, understanding the importance of routine testing and talking to, specifically, we know so many of our students go to practice in Baltimore, specifically, like I said, this area of Baltimore where HIV is ravaging communities. So we kind of take things both from a macro approach and a micro approach. We can go to the next slide. So I think just wrapping up, something important to remember is that the patient has unique challenges and stressors, and so do their support systems, right? So, people are coming at this with the distrust of the system. They often can have no or fragmented support systems. We have to think about stigma when we're talking about our patients, their own health literacy, and their ability to access resources. So our patients oftentimes we think, it's just not that hard. You take this one pill once a day, but the social workers on the call will understand, Maslow's hierarchy of needs teaches us that if they don't have our basic needs met, like safety and food, then we're worried about those things first. When we work in a team, I think that we're really have a better idea of looking at it from that point of view. I think when you're working in a team, you can often remind one another, like, hey, wait, I know that we're really focused on getting this person to take their meds, and that's important, but we've got to reduce some of these other barriers first, whether that be, this is a person who's transitioning, and first and foremost, the only thing that's important to them is a name change. So if we can get them hooked up with the legal clinic and get that going, then we might be able to better engage them in care, better understand and build some trust, see if there's other accesses of support systems that we, in that community that we can call on, and help them to reduce some stigma. They can go by a name that they feel comfortable going by. So sometimes it takes the team to look outside of our own siloed lens of like, this is what I learned, this is what I do, I'm on autopilot. And then conversely, in the next slide, Dr. Frank, we have our own challenges and stressors and ethical dilemmas. So like Dr. Frank had said, we need to also be taking care of ourselves as well. So our provider challenges, our own provider challenges, we've got to also build trust and have our trauma-informed interventions, that we are understanding how to assess the capacity for our patients, talking to people in a way that they understand what we're saying and not trying to prove that we're very well-educated people that could be a lot smarter than, whatever. It's never going to work. We need to meet people where they are. So I think that it's important when we look at the patient stressors that we also look at the stressors that each of our disciplines bring to the table as well. We do better together. Maybe that is a generational thing, but we are improving clinical outcomes when we work together in teams. And so I think that we're seeing that on the daily in our program. And so, I hope that our program can serve as a model for other academic centers that might want to get involved in this kind of work. Do you want to add anything, Dr. Frank? I think that's my last slide. I'm not sure. Oh, no, sorry. The why of our work. So, this isn't, anything here that I'm not going to tell you that's groundbreaking, but HIV is preventable and treatable health issue, and we can end this epidemic. It's essential that we reform our systems of care and change the ways we teach and train our emerging healthcare providers to care for today's patients. So really looking at disparities and vulnerability, the complexities that our patients today bring to the table, poverty, trauma. So we can break the cycle of poor care and be good stewards of the ways in which we deliver care. I think that that's incumbent upon that upstream effect of teaching teaching our students this while they're still in school, rather than, oh, this is how we do it at our clinic. They can come to clinic already understanding interprofessional care and the importance of that. I think that's my last slide. Yeah. Okay. Did you want to add anything, Dr. Frank?
No, I'd really like to hear from the group. And hear what kind of questions they have and what lessons learned do you have and ideas?
So I know that Fatima has been collecting or monitoring the chat. I mean, I definitely have a few questions, but at this time, I'd love for the group to enter into the chat things that you want to know more about, things that you're curious about related to interprofessional education or to any of the elements of the program that Dr. Frank and Abby shared. To me, it's so polished. It's such an exemplar of these different disciplines coming together for the common good and really doing their level best to get rid of that awful kind of hierarchical way of working. That to me is so impressive and really comes through in that amazing video. So please enter your questions in the chat. And Fatima, I don't know if you have, if you want to unmute yourself. And
yes, I do have 3 questions from the chat. So the first question is for Dr. Frank, and it is, if education is one of the social determinants of health and level of education is closely linked to employment level, another determinant of health, why are schools not included in your model?
Why are schools not included in our model?
Yes.
What do you mean, like departments of education?
I'm guessing just
I'll clarify on this one. We have a lot of students who are in the MED school counseling program. And so they're working in elementary schools, particularly in Title I school districts. So they're working in behavioral health in Title I school districts that see and are providing a lot of, and sometimes the only amount of behavioral health care, and sometimes the school's providing the only amount of medical care as well. And so our students are working in elementary schools through high schools, and I believe that that's where the question is coming from.
Yeah, I think it's a great point. And certainly teachers and educators, I graduated from the School of Education at the University of Pittsburgh, so I am an educator. But our grant, the MidAtlantic AATC, we're charged with training health profession teams. And we do a fair amount of training that relate, we've trained, school nurses and, people like that. But educators per se, teachers are not our audience. And it's not that we deliberately excluded them. It's that our charge from our federal funding is to train healthcare providers and healthcare teams. But, we've expanded our audience to include patient navigators and case managers. And, it's something that that we certainly could think about, how we could convince, what kind of people we'd like to include. And, the thing about it is all of us wear different hats. You wear different hats. And, what I do for training for the MAAETC relates to what our legislative language is. But as a professor in the School of Public Health, I can train educators. I could go out and work with school districts and things like that. I've worked with police and, and Abby works within the School of Medicine at the University of Maryland. So we could put our other hats on and be able to do that. So if you want us to be involved in that, let us know. And we'll figure, now I never say no to anything. I'm a baby boomer, like I said, let us know. We'll figure out how to do it. If you want us to come and you want us to do that.
I think it's a great question. And I think that it's a very important component to this and really highlights, like, we continue to work in silos, even when we're trying not to work in silos, right?
Yeah.
We are constrained by our funding. That being said, this is something that at the state level, when we work in our HIV planning groups, we have, in Maryland anyway, been working very hard to get the Board of Education at the table. It's an important puzzle piece. And if we don't have everybody at the table, everybody needs a seat. Educators, school counselors, who's talking about HIV and family planning and what that looks like, and when do we start talking about routine screening and testing? And so you hit the nail on the head. It's a piece of the puzzle that needs to be in part. And I think that our HIV planning groups are getting there. I think they see that and understand the importance of that, that we need police and firefighters and pediatricians and, not just healthcare providers, but also education. We need judges. We need, so we've got a large task at hand, and it's a great question.
The other thing is we never turn anybody away from our training programs. So you can be from any place, any discipline, and come to our trainings. But in terms of developing specific trainings, we would wear our other hats to do that. And that's not an issue. We can do it. So do you have social work interns in Philadelphia schools? Somebody asked that question.
Again, I'll clarify here. Lisa is the director of social work interns in the Philadelphia School District. So she's stating that we also have social work interns. So we're putting behavioral health professionals from many different areas, social work, MED school counseling, and all of that into our school districts, especially these Title I schools. And so that's what, we do find that children are getting most of their needs met through the school district. And I think that's where a lot of these questions are coming from.
Yeah, there was a comment in the chat about, school counselors being trained to work in an interdisciplinary way. So I think working with them would be really beneficial. Absolutely. Just like, there's so many people that we need to work with inside and outside of institutions, Okay, there's a question. Can we speak to effective ways you found to provide accurate information beyond university settings to the general public and current healthcare workers regarding epidemics and public health? Especially curious in light of the popularity of misinformation on social media when it comes to public health. Interesting question, very important question. In terms of, I'll speak for me and then Abby can respond however she wants to respond to this, but I really do think that in working with the general public, it's important that you have the correct information. And I always try to figure out how to translate very complicated things so that anybody can understand them. And that's one of the things I like about, there's a lot of people that do this very well. We have people in our department that can take really complicated things and make them sound that anybody can understand. And so we do that all the time with HIV patients, helping them understand viral load, helping them understand viral replication. You can do it by using models. You can do it by having flip charts available so that, in schematics and infographics and things like that that people can look at, I think are very important for the general public. It's also important to get messages across by using peer educators and people living with HIV to educate other people. That's one of the reasons why I did the prison peer education program, because, other prisoners training other prisoners about HIV infection, that's the kind of stuff that works. The other thing that I think we've done over the years is building upon networks that already exist in the community, to give them information, to let the networks that are in the communities disseminate the information. For example, the power of women and the power of mothers, I think are very important in communities, and grandmothers. Now, I was just talking about this on another webinar about COVID-19. Grandmothers are the ones that remember polio. And so they remember the days in the 1950s when we were lining up and getting those little sugar cubes, and I was one of those kids. And so I would say that I think we need to use more peers in the communities and existing community groups to empower them. And I gotta say, over the years, that some of the major changes in HIV were because of advocates in the community that got things changed. It's not just academics. And, I'm working on a COVID study right now. It's a seroprevalence study that's going on across the country where we're going out and doing COVID testing in random community settings. So I'm going out and sitting down with people to ask them whether they want to get tested. And we have to do these screening questionnaires for it. But lots of times what they really want to know is they want information. So, before I can get anywhere, I've got to spend time talking with them about COVID-19 and the vaccines, because there is a lot of misinformation on social media for sure. So Abby, what are your thoughts about this?
I had written down peer educators as well. I definitely think that's our main inroads into the community and in getting people to get their information from people they trust. And then the other thing I wrote down was travel with the chair. So if there's not a seat at the table, you have one. You brought it with you. Make sure you can sit down. Because I think that all these planning groups and, there's oftentimes we don't have community members at the table, and we need to. And those are the people that we can, that is peer education, right? So if we can get enough people at the table and we can educate it that way, or even to just say, we're doing a, not us at the AATC, but at our state level, the health department level, they were going to do a multimedia campaign about COVID and HIV. And we're working with the local MICA, our art institute, a local art institute. having those messages vetted, and so that people can, are we getting the message across? Is this making sense? And the more people that even we're just vetting the messages on are going back to their own families, to their friends and saying, hey, you know, I was just at this focus group, and I never knew this, but did you know, and X, Y, and Z, and we can inform people that way. I think this is a great question, because when it comes to social media, we know that our phones are based on algorithms around what we look at. And so sometimes there is a lot of information out there, misinformation out there. And it's important that we get that information clarified by people that we trust. That could be our healthcare providers, but often it is our mom or our grandmother or a trusted community member.
So what are all of you telling people about COVID vaccines? Maybe you guys can put it in the chat. You know, there are these mRNA vaccines, right? And there's no virus in it. And, you know, people are concerned that it'll give them COVID-19. You know, it's sort of like that was true for a lot of people who got flu vaccine. I don't want to take flu vaccine because I'll get the flu, right? So what are people thinking about? What's the feedback you're getting out there about COVID-19?
I mean, I think it's kind of difficult sometimes to engage our audience in this setting. And I think, you know, experiences are really different. You know, it is political, you know, it depends on who you're talking to and what kinds of media messages they're digesting and taking in. Let's see, I think there's some more in the chat.
Yeah, people are writing now. People are saying more trouble with accessing the vaccine than misinformation about it with my clients. That's been a problem, for sure, of accessing the vaccine. The governor's just opened up in Pennsylvania, you know, that people are supposed to be able to get more access. By the way, they just you know, changed the status for all the students at Pitt because we've had an uptake in new COVID cases on Pitt campus. So everybody's sheltering in place now. So Dr. Tennille, are you gonna read the comments?
Yeah, I mean, I guess I'm gonna read the comments, but I'm curious about this, you know, the worry that so many people share about, you know, these variants that are out there, and, you know, thinking about like HIV, thinking about COVID-19. I remember in my early years doing HIV work and hearing about how HIV was a sloppy copier. I don't know if you ever remember hearing that phrase. So to me, it was this very simple way of understanding that it's a mutating virus that's always changing and always evolving to find hosts. And I think, you know, a lot of what I'm hearing is, you know, this worry about, you know, well, great, we can get vaccines, but then, you know, are we, you know, that goalpost gets moved in different places. So I think there's vaccine hesitancy, but there's also this worry that the kinds of vaccines that are available right now, you know, are maybe not going to be effective for some sloppy copying COVID-19. You know, I don't know what I'm looking for. The word I'm looking for.
We don't really know because we've never been here before.
Yeah.
Just like we were never there before for HIV. And somebody put in the chat here about how quickly they developed the vaccine. And one of the things I want to say about that is it's because of HIV that we developed the antibody test and the PCR test for COVID so quickly. Because in the early days of HIV, we had neither of those. It was until 1988 before we had an antibody test, and we didn't even have PCR until 1993 when the person that invented PCR got the Nobel Prize for it. And then we were able to determine, viral load for people with HIV. But I see lots of stuff in the chat about most want it but aren't able to get it yet. And many people have the same misconception that it's an mRNA vaccine, and that's true, and it's not. Most of my, and other people say most of my family is willing, but they want to wait for the Johnson & Johnson version due to the trust in the name and feeling like there was more research done.
And there's also a professor that says, that she was surprised to hear that several of her students don't want the vaccine and suspects that some are still living off the misinformation about autism and vaccines.
Right. Even though that autism stuff was retracted and disproved, and it's what we were talking about, it's social media. Once stuff gets into the social media, it's hard to take it back.
Yeah, it's sort of like a fire hose in the chat now.
Yeah.
Which is great.
Thanks, you guys.
Yeah.
This is fun. I'm I'd love to hear everybody's voice though.
I know.
Just like we'd all like to see people together again in the same room. And going out and being in the community again. I miss that so much. Another comment, people are worried that we won't reach herd immunity because of misinformation. I don't know what to say about that. But there are a lot of people that I know in our COVID study that say they not only do they don't want to take the vaccine, they don't want to be tested for COVID-19. It's both of those things. Somebody says we have an elderly patients who have been concerned that the vaccine was developed so quickly. We've explained that the vaccine development has actually been developed over 10 years. Good point. People don't trust it because, especially since it's experimental and there isn't info on long-term effects. Yeah, that's true. But do we, one of the things I often talk about is, do people really know the long-term effects of all the new drugs that are coming out and that people are taking? I'm not talking about HIV or hepatitis. I'm talking about, there's always a risk of that. The new antidepressant, the new hypertensive drug, the new weight loss drug. There's always some kind of risk, because you really don't know until you longitudinally look at it. I've been part of speaking of longitudinal studies, I've been part of the Harvard Nurses' Health Study since 1979, where they follow nurses and they send you questionnaires every year and you give them blood samples and all that good stuff. And so much has been learned about chronic diseases and what makes the difference in terms of diet and exercise and birth control pills and all that kind of stuff for women. And ultimately, that's what we've done with, a lot of the studies for HIV, is we've been now following people over time. We've been following men, we've been following women, we've been following what happens to babies of pregnant women that get antiretroviral agents. Their mothers take antiretroviral agents. And that's what needs to happen with this too.
So, Dr.
Abby, you want to take any of these questions?
I have a really good question that's in the chat for either of you. And it says, what can be done about the inequities and inaccurate information? How can we get accurate information to communities that have an understandable mistrust of the medical community or may not understand the language used in the pamphlet / on the news?
Yeah. Well, you know, I want to say that communities, minority communities have reason to be suspicious. Things have not been great in the past, as you all know about Tuskegee and all those kinds of things, which still resonate now, and why some people perhaps don't want to take vaccines. So I think for me, it's everybody's got to understand, you know, that was a trauma. And people have to understand that there are going to be people that we're not going to convince to take the vaccine. They're just not going to do it. And that has to be okay because it has to be a choice. I think also one of the things that we have to also do is we have to look more at who's coming into our professions. And we have to do more to attract, you know, a diverse workforce to work in healthcare. And that's been an ongoing issue for for as long as I've been a clinician. You know, if you look at nurses, you know, for example, all the nurses is the largest health profession in the United States. And I always say to nurses, you know, and if you look at the number of minority nurses, it's very low. It's gotten a little bit better. The same has happened in medicine. I don't know what it's like in social work and, you know, other areas. I think probably Dr. Tennille, you might be able to have more data on this. And Abby, what are your thoughts about it?
Sorry, I was muting. I was muted, sorry. Sometimes I wonder too, you know, we're talking about medical mistrust, which 100%, I think you're right. Also, are we offering the vaccine in communities, you know, where it's easily accessible? Are we allowing, you know, our minority communities to be vaccinated at the rate that we're offering our white communities to be vaccinated? I know in DC they have programs. There's certain days that you have to live in a certain zip code. That's the only way you can get the vaccine that day. Really, in Baltimore, they've just built a whole task force to try and get, you know, vaccine distribution to be more equitable. So sometimes I've been reading that we're hiding behind the, you know, there's medical mistrust, and that's why people of color are not taking the vaccine. I think that's true to some degree. I also think that we need to get the vaccine into the hands of people who want them. And I'm not sure that we're always offering it in the right places. Because I think sometimes we don't have people at the table that need to be there. Sorry to keep bringing that up, but I think it's true. Yeah, so Sean just said the same thing. And then, you know, as far as educating people who, sorry, I'm reading well. As far as, you know, getting education out to the people, I think it you know, it kind of goes back to the question that we answered earlier. You know, we have to educate community members, not just our medical professionals, so that we are making sure that, you know, where you get your hair done and all those things. But this is a really, I don't know, the internet is undefeated. I'm not sure that we're going to win against the algorithm of your phone just by educating community members. So, and I'm not trying to be an alarmist or defeatist. I just think that, you know, it really is going to be important to keep having those community conversations, to keep talking to your friends and family and ask them to pass the information on. Because I you know, it's we're going up against a hard mechanism here, the internet.
So I want to just sort of, you know, maybe one final question, you know, ask the question that Noelle asks. So Noelle says, I'm a person of color and my friends of color and family members who are skeptical of the vaccine are so not from previous experiences, and in parentheses Tuskegee, but current negative experiences from the medical community. And that's the more potent, you know, kind of, I guess, barrier to access. So I think important observation, something for us to think about tonight.
Yeah, and seeing yourself matters, right? So if your doctor doesn't look like you, and there's a lot of good reason for distrust. So proximity matters. Seeing yourself and the relationship with your physician matters. We hear that from patients all the time. Like, well, you don't have a young gay Black provider, so it's hard for me to feel like I trust this white woman who's telling me what to do. So of course, yeah, I could see that. I think that's really, really real, really valid for sure.
The only other thing that I would add to that is that I think we need to get people to take on the advocacy role. Getting people from all groups to get input into how decisions are made within healthcare systems. And I think that's happening more now. There's not a movement afoot at the universities and healthcare plans that all have, new initiatives around equity and inclusion. And I think it becomes an opportunity for all of us to become advocates. And I've spent years being an advocate on Capitol Hill for HIV, beginning in about 1995. And now I go down and talk about other things too. And this is certainly going to be one of them for me as well. And I never thought that I would have any impact on Capitol Hill. I never thought about doing it until I actually did it. And it's become a passion for me. And so I would encourage everybody here that's listening to get yourselves and people in your community to go to town hall meetings, to meet with your city council people, to meet with state legislators and federal legislators, and getting them to make changes.
So Dr. Frank and Abby, I think we have one more question for you. Fatima is saying that there's a question that's come up twice in the chat. So Fatima, if you want to ask that.
Sure. So this is about the IEP program. And the question is it just certificate programs for already working professionals to get more people working in the same model?
Abby, you want to talk about?
Yeah, thank you. Right now it is just at the school and for students. That mostly has to do with the clinical side of the work, but anyone's welcome to take the didactic trainings. And in fact, during COVID, since we moved everything online, a lot of people are taking advantage of that. We have quite a few community members, people from other states are getting involved in sort of our clinical pathway of trainings. As it relates to the certificate, I think that clinical side of the experience is really important. And until we were able to provide that on a larger scale, and certainly not in this COVID environment, are we able to do that yet? But it's something to consider for sure, because you're right, it would greatly increase the workforce capacity, and that is one of our desired outcomes. So I think that's an important point. And to that point, though, we haven't had anybody ask for that certificate program, but that might come up now that everything is advertised online and available online. So I think we'll put that in the back of our heads, and I appreciate it.
And Rodney Lewis in the chat says, engaging with outreach to underserved community agencies that have gained trust of Black and Indigenous people of color with local churches and community centers. Very important. And I would also add, high rises and, other places where people naturally congregate. So good point, for sure.
Well, I have to say that I feel like we could spend a lot more time with the two of you. Your presentations were wonderful. Dr. Frank, Abby, we thank you so much for just generously giving of your time tonight and just, kind of dealing with this awkwardness of, chat questions and things like that. But I'd certainly love to continue our relationship. And really, when we can kind of come back online and see each other in person, we'd love to have you come to Westchester University and meet with us. I'd love to visit, I'd love to go with Wendy and maybe the rest of the team to, Baltimore and kind of check out your program, Abby. And that sounds really interesting. I'm also so interested in your standardized patient element. We're working at that here at Westchester and doing simulations and things of that nature. But we have a lot to learn from you. And I think I can speak for folks that we really, really enjoyed what you brought to our interaction tonight. So thank you so much.